Welcome students to Chapter 6, Disorders of Trauma and Stress. And in this chapter we're going to be looking at post-traumatic stress disorder and other types of disorders that arise when people are subjected to very difficult circumstances. First we'll take a look at the components of stress. So a stressor is an event that creates demands. It causes fear when it's viewed as threatening. And a stress response is a person's reaction to those demands. Extraordinary stress and trauma, we know, can play a central role in certain psychological disorders, and that's what we'll talk about today. So, stress and psychological disorders, some of them are acute stress disorder, post-traumatic stress disorder. DSM-5, which is now in text revision, lists these as trauma and stressor-related disorders. And then there are stress and physiological disorders. They are listed under psychological factors affecting a medical condition. So when we look at stress and arousal, or the fight or flight response, the features of arousal and fear are set in the hypothalamus. Two important systems are activated: the autonomic nervous system, or ANS, which is an extensive network of nerve fibers that connect the CNS, which is the brain and the spinal cord, to all other organs of the body. The other system is the endocrine system, and a network of glands throughout the body release hormones, so that also kicks in. So here's the fight or flight response, and you can see that all of these different organs, the lungs, the liver, all sorts of things are either stimulated or inhibited by the fight or flight response. And that is the sympathetic nervous system, where the nerve fibers of the autonomic nervous system quicken the heartbeat and produce other changes experienced as arousal. Conversely, we have the parasympathetic nervous system, where the nerve fibers of the autonomic nervous system help return the bodily processes back to normal. And that's what we want to try to do to bring down some of the overactivity that happens in stress. So two pathways by which the autonomic nervous system and the endocrine system produce arousal and fear reactions. Again, the sympathetic nervous system pathway and the hypothalamic pituitary adrenal pathway. So we're talking about first acute and post-traumatic stress disorders. Acute stress disorder is where there are fear and related symptoms that begin within 4 weeks of a certain event that's anxiety-producing and lasts for less than a month. But PTSD, or post-traumatic stress disorder, is when fear and related symptoms may begin either shortly after an event or a month or years afterward. We know that 25% of people with PTSD do not develop a full clinical syndrome until 6 months or more after their trauma, and at least half of all cases of acute stress disorder develop into post-traumatic stress disorder. Aside from differences of onset and duration, the symptoms of acute stress and PTSD are almost identical. We have increased arousal, anxiety, and guilt, the re-experiencing of the traumatic event that caused it. We have avoidance of similar events and circumstances, and reduced responsiveness and dissociation to the environment. Other characteristics to note: they can occur at any age and affect all aspects of life, that they affect at least 3.5 to 6% of people in the United States every year. It's more common among women and people with poor financial status and discrimination experiences. So what triggers these stress disorders? For men, oftentimes it's more common that they suffer from this from combat. It used to be called shell shock or combat fatigue. Now we typically call it post-traumatic stress disorder. Also, disasters and accidents like hurricanes, which we certainly have here, and traffic accidents can produce PTSD or acute stress, and then victimization such as sexual assault or rape. Other triggers include terrorism, like 9/11 or mass shootings, and then experiences of torture, including physical, psychological, sexual, or deprivation. We know that there are biological factors that are involved in these disorders. There's a brain-body stress root that gets activated. The brain stress circuit comes into play, and there is an inherited predisposition to be more susceptible to trauma. Childhood experiences that increase risk for later PTSD include chronic neglect or abuse, poverty, parental conflict, catastrophe, and family members with psychological problems. Cognitive factors and coping styles that might predispose you would be pre-existing memory impairments, intolerance of uncertainty, inflexible coping styles, and negative worldviews, as opposed to resiliency and manageable stress exposure in childhood. We know also that social support systems, such as weak family and other social supports, can predispose one to have trauma. So how do clinicians treat acute and post-traumatic stress disorders? For combat veterans, many times antidepressants are used, cognitive behavioral therapy, couple or family therapy, group therapy, or community interventions. And I'll note that psychological debriefing or critical incident stress debriefing, where people are asked to talk about their experiences right after, has not been supported in the literature over time, so it's not used a lot anymore. Exposure treatment is the best intervention with people that have PTSD, and according to the research. Earlier treatment looked at in vivo exposure being more effective than covert exposure, but now virtual reality is used as the standard in PTSD treatment. It's becoming more and more common in treatment of other anxiety disorders and phobias as well. So in addition to stress, stress disorders, another type of disorder in this overall category is dissociative disorders. This is a group of disorders that are also triggered by traumatic events. When changes in memory lack a clear physical cause, they are called dissociative disorders, where one part of the person's memory typically seems to be dissociated or separated from the rest. Types of dissociative disorders include dissociative amnesia, and a subtype is dissociative fugue. Dissociative identity disorder, or multiple personality disorder as it used to be called, is another one, and that's where there are subpersonalities or alternate personalities that a person develops. In dissociative amnesia, there's an inability to recall important information, usually of an upsetting nature about one's life. Memory loss is much more extensive than normal forgetting, and it's not caused by some physical factor. Often in the amnesia episode, we have a trigger by a specific upsetting event. Checklists for dissociative amnesia. This is where a person can't recall important life information, typically traumatic or stressful information, that leads to significant distress and impairment. This is not caused by substance or medical condition. In dissociative identity disorder, this is where a person experiences a disruption to his or her identity, and so at least two separate personality states or experiences of possession are developed in the person. And the person repeatedly experiences memory gaps about daily events or key personal information or traumatic events beyond ordinary forgetting, leads to clinically significant distress or impairment, and again, the symptoms aren't caused by a substance or medical condition. In dissociative amnesia, localized is the most common type, which is loss of all memory of events occurring within a limited period. Selective dissociative amnesia is loss of memory for some but not all events occurring within a period. Generalized situation is where there's a loss of memory beginning with an event but extending back in time, and a person may lose sense of their identity and may fail to recognize family and friends. And then continuous dissociative amnesia is where forgetting continues into the future. It's very rare in this type of problem. Dissociative fugue is the most extreme version of dissociative amnesia, and people not only forget their personal identities and details of their past, but they flee to an entirely different location, and it may be brief or it may be more severe. And then we have dissociative identity disorder, which is the multiple personalities, where each person or personality has a unique set of memories, behaviors, thoughts, and emotions in the person. There's a sudden movement from one subpersonality to another that's triggered by stress. Women are diagnosed with this 3 times more often than men are. In terms of how common DID is, it was traditionally believed to be rare, but the number of people diagnosed has increased over time. Although the disorder is still uncommon, there are thousands of cases that have been documented not only in the United States but Canada. Despite changes, many clinicians continue to question the legitimacy of this category, though. From a psychodynamic perspective, dissociative disorders are caused by repression, where people fight off anxiety by just unconsciously preventing painful memories, thoughts, or impulses from reaching awareness. Dissociative amnesia and fugue are single episodes of massive repression, and DID results from a lifetime of excessive repression motivated by very traumatic childhood events. State-dependent learning is something we want to touch on as well. This is a cognitive behavioral view. They note that there is a link between the person's state and their ability to recall. Learning can also be associated with specific mood states. And arousal is important in learning and memory. So a particular level of arousal may be attached to a set of remembered events, thoughts, and skills. So how do therapists help individuals with dissociative amnesia? Psychodynamic therapists guide patients to search the unconscious and bring back forgotten experiences into consciousness. In hypnotic therapy, patients are hypnotized and guided to recall forgotten events. With drug therapy, there are intravenous injections of barbiturates that also help people regain lost memories. Therapists work with people to try to help clients recognize fully the nature of the disorder as well. They recover the gaps in their memory, and they integrate subpersonalities, if it's DID, into one functional personality. And last but not least, I want to touch on depersonalization and derealization disorder. This is a dissociative disorder, but not one as categorized by the memory difficulties found in other dissociative disorders. The central symptom is persistent or recurrent episodes of depersonalization or derealization that affects around 2% of the population, most often adolescents and young people. It's triggered by extreme fatigue, physical pain, intense stress, substance abuse recovery, or being a survivor of a life-threatening situation. In depersonalization, you feel separated from your body. You see yourself from the inside out. There's like a doubling effect. You may have a mechanical, dreamlike, or dizzy feeling. There's an awareness that your perceptions are distorted. And then with derealization, there's feeling the external world is unreal and strange. There's changing object shape or size, and you may see other people as robots. So depersonalization and derealization are very stressful as well. And that concludes Chapter 6. We'll pick it up in Chapter 7.